Hi, everyone. Welcome to the Chapter 17 review. This is just going to give us a quick rundown of some of the concepts that we covered in Chapter 17, of course, just like all the other stuff. So, first of all, some of the reason why science thinks that we are having so many issues with either hypersensitivity or hyposensitivity as far as our immune system response goes, that they gave us the hygiene hypothesis. And that is the concept that we are, as developed countries, as first world countries, and industrialized, essentially, we're not getting exposed to the same microbes that we would have been in the past. And so because we're not seeing those microbes and becoming sensitized or desensitized appropriately, then our immune system is not reacting appropriately to things that it's seeing in its environment. And so that's the idea of where allergies came from. Immunopathology was another term that we brought up in this chapter. Immunopathology, I want you guys to be aware, that term refers to any sort of disorder in the immune system. So it could be hypersensitivity or hyposensitivity, and it even includes autoimmunity. So we'll start with hypersensitivity. There was the type 1 hypersensitivity. This involves IgE. So that's, remember, a type of antibody that we could produce. And what we see, you can have an atopic response or an anaphylactic response. And within the atopic response, which is a local allergic response, this will include allergies, the typical allergies, what we see, as well as asthma. So that counts as well. Then anaphylactic shock is going to be our systemic response. So that's overreaction for a systemic response. So we talked about these allergens being able to get into our bodies via inhaling, being contacted, injectants. Those are like, even includes not just needle injection of something, like if you're allergic to a drug, but also includes like bee stings and wasp stings, and then ingestants, things that you would eat. So there's food allergies there. These all involve an initial sensitization. We produce the IgE. The IgE gets produced by our plasma cells, and then the IgE will stick onto the mast cells and go around and grab on to allergens, which of them are antigens in the area in the bloodstream and whatever. And then the mast cells will degranulate and release all these chemicals that are involved in the allergic response, essentially. It thinks it's doing a good thing, but it turns out it's just annoying. So that would be what would happen after we've had our initial sensitization. And then once we have been desensitized, we can react instantaneously. Like those mast cells will stay in that tissue and stay there and wait with the IgE, just waiting all the time. So it can be an instantaneous response, pretty much. That's just the worst. All right. So we can treat these if we have atopic allergies, things like just plain allergies or asthma, stuff like that. You can treat these with antihistamines or steroids, something like that, or any sort of anti-inflammatory drug, right? So it would include steroids, but all right, and some of the non-steroidal anti-inflammatories as well. Anyways, they're not good for you to take long term. It can be very difficult on either your body, like your stomach and everything like that, or with the steroids, it can be really hard on your immune system and cause you weight gain and all of this stuff. So you don't want to do it long term. And then we have epinephrine and adrenaline. Those are the same things. Those are going to be used to treat anaphylactic or systemic shock. It has a very short, it's very short-lived. The response will work quite quickly, but it's very short-lived. So it will get you enough time to get to a hospital, but you do need to seek treatment. All right, next we have type 2 hypersensitivities. Type 2, these are going to involve IgG or IgM, and this is going to lead to complement-mediated lysis of the cells that these are binding onto. And these cells are going to be your blood group cells, your ABO group, as well as your RH group, positive or negative. We talked about the ABO blood groups themselves. Remember, A has A on its surface, so just think of it as having A's everywhere, but everything, here's how, this is a better way to do it. This is the surface of the cell. If you are a type A, then on your surface, you have this. Okay, if you are a type B, then on your surface, you have this. If you are an AB, then on your surface, you have this. Not this, okay? Not that, this, okay? And then if you are O, on your surface, you have this. Now, they all have something in common. Okay, so O is the baseline. Anybody can get O. Nobody is ever going to see O as foreign. However, A's, they see this junk as foreign. B's, they see that as foreign. Okay, to them, they've never seen that. Will react against that. ABs, they're good to go. They've seen A's. Fine, give me A. They've seen B's. Fine, give me B. They've seen O's. Fine, give me O. So, and they've seen AB together at the same time. Ooh, give me AB. So these guys down here are the universal recipients. And the O's, because everybody's got that same O structure on there, anybody can get it, then nobody sees it as foreign. These are the universal donors. Hope that makes sense. Okay. So those are the ABO aspects. The RHs are pretty similar, except it's like RH negative is like the O, and RH positive is like, it doesn't matter which one, has something on the surface, the positive. Okay. So that would be look bad to the negatives. And that is what is involved in hemolytic disease of the newborn, which is whenever the mom, who is RH negative, has an RH positive baby at first, builds up antibodies to the RH positive once that baby is old enough to make its own blood and it has RH. And nothing happens, it's fine. The second baby, though, we've already been sensitized. We've already seen it before. So now we can just kick out that antibody as soon as that baby starts making it. It's not till later in the pregnancy. So a lot of women, when they have this sort of a thing and they didn't know and they didn't realize and you had no idea, end up losing their baby late in the pregnancy. This is deadly to the fetus. So that is the RH positive, RH negative hemolytic disease of the newborn. Okay, next is the type 3 immune complexes. We talked in this chapter about so immune complex, we basically have antibody. So just pretend like this is definitely looks like an antibody, and it will bind with its little antigen, but then other antibodies also getting excited about it. And then this antibody is getting a little excited about it. And then this one's got an antibody and this guy is excited about it. And I don't know how to draw this, but whatever, whatever. It's terrible drawing, but you get the idea, right? It's making this big old web essentially of antibody antigen complexes. That's exactly what it is. The bigger ones get destroyed by the body naturally. The kind of problem causing ones, kind of medium-sized ones, they get to float around in the body. They get stuck in certain like basement membranes of certain tissues. And then that causes a complement cascade, which causes inflammation, of course, and destruction of nearby tissues. And then we have also the neutrophils that come and degranulate. And when they do that, that causes, production of inflammatory cytokines and call to arms kinds of cytokines, and essentially causes damage to the entire tissue around the region. So it's quite severe, quite significant. So we had mentioned acute post-streptococcal glomerulonephritis, which is exactly what we are mentioning, what I just told you. We have the immune complex, but in this case, the immune complex is getting stuck in the basement membranes in the glomeruli in the kidneys. And that as a result of that, we had that same complement situation as well as the neutrophil situation, lots of inflammation and tissue damage, and that can cause a severe damage to kidneys. So bad kidney damage. Cool. Next, the type 4, these are delayed, cell-mediated. They involve T cells That's the T cell response that's going to be involved here. Okay. This includes our response to PPD tuberculin test, the little injection you get under your skin. Did they look for, swelling in 24 to 48 hours? And that if you do have that swelling, that would happen within that time frame, and that indicates that you have delayed cell-mediated T cell type response to tuberculin, which means you have seen tuberculosis or tuberculosis protein of some kind, like what they use in the vaccinations, that you've seen it at some point, right? So that's how that works. It also is involved in contact dermatitis, including poison ivy. Your body is basically attacking your own cells with your T cells that are touching on to that, poison ivy oil or whatever it is, and is seeing that whole area as just like, let's kill it all because it sees it as bad as it is. So then we have graft rejection is also something that is tied in with the type 4 hypersensitivity. This could be host versus graft or graft versus host. It does require some sort of initial sensitization, but within time, there will be a reaction. Again, it will take a couple days, but you will see it. So host versus graft, we have the host body, just our normal T cell system, recognizing our the MHC molecules. Remember, those normally will trigger, interact with our T cells and allow them to communicate with one another to see the antigen they're holding as being foreign. Well, instead, we have a new kidney from somebody else, and our T cells coming along and seeing the MHC and saying, this is foreign, even though it doesn't have anything in it. It just sees the whole thing as foreign. So that's usually the MHC or HLA, same thing, that are involved in that reaction. So let's see. Then so that's our body attacking that tissue as a result of that. Then we have the graft versus host, in which case we have bone marrow from a donor that would be consisting of, lymphocytes. So their lymphocytes from the bone marrow will come out and attack our cells in the vicinity and throughout the body, given enough time. Causing that sort of a reaction that way. So that is the graft attacking the host, but that will be with bone marrow. Then we have the different kinds of grafts that you could receive. The autograft, that's from yourself. The allograft, that's from your somebody else. These weren't in the same order. Sorry, made me pause for a minute. Allograft is from somebody else, just rando person, not immediate genetic relation. Isograft, that's your twin, and xenograft is from an animal, like we said, with pig valves. All right, then we've talked about autoimmunity. We got into the little bit of details on lupus and rheumatoid arthritis, which were systemic. And then we had Graves and type 1 diabetes, which were endocrine. So those were local. So Graves is just attacking the thyroid and causing overproduction of thyroxine, which leads to hyperthyroidism, but that can affect the whole body. And then type 1 diabetes, of course, we're attacking in the pancreas, the cells that are involved in insulin production. So, right. So immunodeficiencies, moving on to those now. These are our hyposensitivities, right? So immunodeficiencies, this is going to be either primary or secondary. Primary ones, this will be from birth, existing from birth. This includes SCID. We talked about SCID and other diseases. And SCID is a severe combined immunodeficiency that involves almost a complete destruction of all of your lymphocytes, B and T cell. There's other diseases that kind of fall in between. DeGeorge syndrome, that's what I was trying to think of. DeGeorge syndrome being one where we have attacking of the the thymus, so that we have improper development of T cells and can't respond appropriately to infections because of that. T cell ones seem to be a little bit worse than B cell related ones because the T cells are necessary for activation of the B cells. So we need the T helper cells for mediating a lot of stuff. So that's why we would see that. So that is genetic, right? So those are primary. Primary is genetically related, is caused because of your genes say be bad. And then we have the secondary immunodeficiencies that are acquired immunodeficiency. So acquired immunodeficiency syndrome, of course, we know that is caused by HIV and leads to AIDS whenever we have a sufficient depletion of the T cells. So not surprisingly, it relates correlates pretty well with the T cell diseases, just because we're going to have elimination of the T cells. And then we have an increase in opportunistic infections as well as cancers in those cases, and a wasting effect eventually. And then we have chemotherapy. We have chemotherapy that can cause depletion of literally that can kill off your immune system, hopefully temporarily, and that you could get it back later, but it can lead to being susceptible to infection. And then it had talked about just having certain kinds of cancers that can affect the immune system themselves, things like leukemia or B cell overproduction, leading to essentially cell overproduction, so that they are not functional cells, not doing their job properly. They're just doing BS. So the ones that should work properly can't anymore. So that is that for chapter 17, and I'm going to call it a day, and I will see you guys next time.